rise in usefulness. And so, there's been a lot of talk, certainly in the urologic community globally, about what should be the best practices. And so, I've written on the subject and I have a long interest in it. And certainly the Canadian Urological Association is taking a look at it. And I understand that you as an organization is also very interested. So I'm going to present tonight some of the evidence that myself and some of my colleagues have begun to collect and amass as part of a policy or best practices paper on behalf of the Canadian Urological Association. Now, it's certainly not published yet, so a lot of this is my opinion, but also we've certainly done a deep dive into the literature for the evidence. So these are my disclosures. I'm a consultant for a number of companies, including some catheter companies that sponsor events like tonight. So in terms of an outline, that was essentially my brief introduction. I'm going to talk a little bit about the methodology and how we review literature. There's a number of different modalities for catheterization. And then how do we actually assess them? Well, we need to have outcomes. And some of the outcomes we look at will be catheter-associated UTI or CAUTIs, urethral complications such as bleeding, stricture, or trauma, something called PROMs, which is patient-reported outcome measures, and that really reports, quality of life, how well patients do or don't do, and cost effectiveness, and then a few final concluding thoughts. So, what we really need to do is try and review the available evidence to address the current management pathways for typically neurogenic lower urinary tract dysfunction using intermittent catheterization. That was sort of the mandate that we've looked at. And so, it may be non-neurogenic, but typically neurogenic patients are the ones who mostly have to use intermittent catheterization. So I'm going to talk about this neurogenic group. There certainly is an association with an increased risk of infection, stones, and compromised kidney function. And, 100 years ago, people would die from chronic retention and the complications associated with having to catheterize. But certainly there's a significant current economic burden and quality of life factors that have to be considered. And we know that really good drainage of the bladder is a cornerstone for good urologic management of neurologically impaired patients. And it remains, intermittent catheterization, the gold standard to which we drain bladders. So what's our goal? Our goal is really to improve quality of life and social rehabilitation for these patients. The problem, though, is that there's a real limit in the amount of high-level evidence available to crucially look at intermittent catheterization and look at its ramifications both in outcomes and quality of life in different populations. So that's a challenge. So when we talk about different modalities of catheterization, we can divide it. We can think about intermittent catheterization compared to indwelling urethral catheters. We often may present suprapubic catheters, and then pharmacotherapy, which would be, we're not really going to touch upon that, but again, a way to manage the bladder. And so certainly there are a number of advantages of intermittent catheterization, IC, compared to indwelling urinary catheters. And those include improved self-care and independence, reduced risk of common indwelling catheter-related complications, the reduced need for equipment like leg bags and drainage bags. There's demonstrated to be a reduced risk of urinary tract infections, UTIs. There are less barriers to intimacy and sexual activity, something which is often overlooked in our patients, and potential for reduced lower urinary tract symptoms between catheterizations. So a number of, I think, really important advantages. And so in terms of recommendation, appropriate bladder management strategies should be personalized. We have to think about anatomic factors, bladder characteristics, cognitive and motor function, patient preference is important, and also quality of life. And so far we know that clean intermittent catheterization is associated with fewer catheter-associated UTI, CAUTIs, compared to other modalities. So we really want to try and use it when it's possible. And if it's not possible, we want to have what's called a closed catheter drainage system to allow for aspiration of urine, for example. And again, we want to try and keep it as a limited time as possible. But there's really actually not a lot of data regarding suprapubic catheters over urethral catheters for long-term prevention of these complications. And so there isn't a huge push towards putting SP or suprapubic catheters in. So what about the outcome measures? What do we recommend? And we'll go through each of these. So first, let's look at catheter-associated UTIs, or CAUTs. So we've looked at a number of ways to assess the evidence, because the goal of this talk tonight is really assessing the evidence of catheterization. So we're going to look at two main areas with respect to the outcome measures. One will be catheter material, and that can be divided between either hydrophilic or an uncoated catheter. Then I think that's actually a repeat of different types of hydrophilic catheters. And then there's pre-lubricated versus non-lubricated catheters. And then technique is important. We have the idea of a clean technique versus aseptic, and then single use versus multiple use. Those are the different factors. So there's definitely a wide variation in clinical practice in terms of intermittent catheterization techniques. And some of those factors specific to the catheter have implications for technique. And so if you have a coated catheter, they have these new standard or versus these compact catheters that can sort of telescope open. And that has implications in terms of patients' manual dexterity, which they may want to use. There's also sterile versus clean. So those single-use ones are typically sterile. And once you start reusing them, they're clean. Or we hope they would be clean. And then the catheter design, as well as whether the catheter is being done by the patient themselves or by a caregiver. So when we talk about catheter-associated UTIs, essentially you have to have symptoms of a UTI, so dysuria, burning, for example, increased frequency, and demonstrable bacteria on a urine culture. We simply would not do a dip of urine, and it's important to remember that the specimen has to be taken as close to the bladder as possible. Collecting it from the bag is totally wrong because it will definitely be colonized. And having simply white blood cells or pyuria should not be interpreted as an infection, and therefore you shouldn't really treat it. So what are the signs and symptoms? Well, it's new onset. Fevers, rigors, particularly in the older patients or maybe cognitively impaired, whether there's a change in their mental status. You might see patients, sometimes they're in a wheelchair, they become just more lethargic with some malaise. And they can also have pain in their flank as well as blood in the urine and discomfort. So I would say those are some of the common ones. And then those with spinal cord injuries, you're looking for increasing either spasticity or even autonomic dysreflexia are some of the symptoms that they may be having in a catheter-associated infection. So catheter material is important. Many catheters come uncoated. So it's just simple latex or PVC, and there's nothing special on it. Hydrophilic coated catheters are a little bit more sophisticated. They have what's called a lubricious coating, which just allows them to slide through the urinary passageway more easily without trauma or friction. So that's hydrophilic. They like water. So believe it or not, there's actually only been 3 reviews and 1 meta-analysis comparing hydrophilic coated catheters to just your standard PVC. And you can see there that the evidence shows that there's a tendency for less frequent UTIs with hydrophilic coated in the one. The second shows significantly less with single-use hydrophilic catheters. Again, the third one, lower rates of UTI incidence in the hydrophilic catheter. And then the last one showed with UTIs decreased risk of infections when you used it single time. So the evidence is leaning certainly towards hydrophilic coated catheters, and there's actually only 2 prospective studies. And the first one showed reduced rates of infection with the hydrophilic, and then the last one actually didn't show any difference at all in symptoms between the 2. So there was this big meta-analysis. And remember, the robustness of a meta-analysis really depends on how many studies you put in. So if on the previous page there was only a few studies, this meta-analysis is somewhat limited. It's looking at 4 studies, for example. But they did find, statistically, that hydrophilic-coated intermittent catheters significantly reduced the risk of urinary tract infections compared to those uncoated catheters. And that black diamond towards the middle is what you would consider the favoring of the hydrophilic. So definitely crosses the midline and is significant. So I think there's different types of catheters. This one, hydrophilic versus hydrophilic, really means, are all hydrophilic catheters the same? And actually, there was no difference between these ones. The other ones they looked at were pre-lubricated versus lubricated. And they found that the pre-lubricated ones were a little bit better in terms of reducing urinary tract infection. So that's quite good. And there's a very limited look at antimicrobial catheters. So that's something that maybe could be good for future research, but there really wasn't a recommendation for using them in the long term. And we don't typically recommend these very expensive catheters for patients who have recurrent UTIs. Now we get into an area that I think is a little bit controversial, and that's catheter technique. And this is the idea of clean versus aseptic. Certainly when aseptic is sterile, this is like operating room, single use, really minimize touching, touch only on the end of the catheter. And what they found was that there's a reduction in the incidence of urinary tract infections, so that's symptomatic infections, but there's actually no difference in terms of bacteriuria. So that's two really nuanced but important things to differentiate. Bacteriuria is just the presence of bacteria in the urine. That's actually okay. And in fact, we would expect the majority of patients with neurogenic lower urinary tract symptoms like spinal cord, spina bifida, anyone who's using a catheter, they're going to have bacteriuria. Bacteriuria will actually turn into a urinary tract infection when someone becomes symptomatic. That is really important. So we have many patients who you chest detect the urine and they have asymptomatic bacteriuria and you don't need to treat it and the catheter doesn't really matter. But when it turns into a urinary tract infection, the real deal, there is a difference between sterile versus non-sterile. And I wonder whether there's something that almost activates the bacteria to get into the urinary tract. And it may have to do with the technique. It may have to do with the fact that catheters are reprocessed and it degrades the lining. Therefore, you can have almost these micro traumas allowing for the inoculation of the bacteria. So there's a number of theories, but it's important. And then there's actually been a few studies looking at single use versus reuse. The evidence is a little weak, but certainly in those who reuse catheters, they're not a big difference in terms of the bacteria or the UTI. So this is where it gets a little bit dicey in terms of what we can recommend. The problem, though, is that these studies really are small numbers of patients, short periods of time, and they're not really well stratified. And so it's hard to draw a conclusion around that. This is an article that I actually wrote with some of my fellows and students, and we looked at single-use catheters, hydrophilic versus uncoated. And we actually found that they did impose a lower risk of infection in pretty much all studies, except that one in children. And so our recommendations were, patient adherence to a cleaning method is really unpredictable. Sometimes we recommend boiling or dipping it in vinegar or washing with soap and water, and you can't assume that everyone's going to do it the same way. And so that's really going to amplify the risk of complications and their need to access the healthcare system. So what we recommended was actually a patient-centered approach. And if we could consider hydrophilically coated catheters as a first option, if they could afford it, if it was available to them, that would be the best option. And again, we felt that single-use uncoated catheters would probably be a good second option. And then finally, lower down on the recommended list would be reuse of catheters if they had a difficult time handling the other ones. So that was the conclusions that at least we made from our literature review. Now, this is a very interesting. In 2014, the Cochrane Review actually did a study trying to do this meta-analysis. And they came up with the following conclusion, that despite a total of 31 trials, there's still no convincing evidence that the incidence of UTI is affected by either aseptic or clean or coated or uncoated or sterile or multiple use. And so they kind of left it open. But then there was subsequently another meta-analysis by another group who actually saw that it favored hydrophilically coated catheters because they had lower incidence of UTI. And as a result of that, the entire Cochrane Review actually withdrew the original Cochrane Review. So they made a recommendation. Other people also did the research, kind of went against the Cochrane Review, and the Cochrane Review said, maybe we don't have this right. And they actually withdrew the entire publication. So it's very interesting. You can sort of see the controversy here, because the Cochrane Review is sort of like the holy grail, and yet even they admitted that they didn't do it quite well. I'm going to skip through this, but essentially there's been systematic reviews, even here in Canada, showing that it's very hard to make a conclusion between reuse, to make an argument to reuse it between the two, because they just lack the proper comparative studies. What's interesting in the blue is that when you look at regulatory agencies, if you look at the FDA, they come up with a statement that says single-use devices that cannot be reprocessed safely should not be reused. In the United Kingdom, they actually make a similar statement that off-license recommendations for the use of these catheters really shouldn't be done, and there's a better quality of evidence is required. And then I believe the last one is actually interesting. The Society of Urologic Nurses stated that the reuse of a single-use catheter is considered off-label, and a new catheter should be used in every intermittent catheterization to prevent infections. And so in the United States, whether you have Medicare or Medicaid or the Veterans Association, they actually fund people to get 150, 180, whatever it is, numbers of catheters per month covered, because they do recommend single use. So Canada is actually an exception in the world. So I would recommend a hydrophilic catheter or something pre-lubricated, single use if possible. It's been demonstrated to decrease infections. We don't use these antimicrobial coated catheters, but there are really no high-level randomized trials available. So it's a tough recommendation. The next one we look at is urethral complications. So are we able to safely pass these catheters through the urethra into the bladder and cause no trauma? So there's a number of markers. It could be the presence of blood in the urine, either microscopic or causing enough trauma that you can see the blood. You could quantify cells left on the catheter, or you could actually count the number of times there was trauma related to bleeding. So you cause a false passage or difficulty with bleeding episodes. There's generally in this situation not a standardized definition for microscopic hematuria associated with catheterization. So we don't really know how much trauma is enough trauma. There have been at least 6 randomized studies assessing hematuria in patients with either the hydrophilic versus the standard. Only one of the studies showed a significant decrease in gross bleeding with the hydrophilic. But however, 3 additional studies showed a decrease in the microscopic hematuria with the hydrophilic. So again, the evidence is sort of leaning towards hydrophilic as a superior product, let's say, or advisable on these surrogates for urethral trauma. Same thing here. They looked at different types of hydrophilic, and they really couldn't see a difference. So there isn't a difference really between which brand or the type of coating that they use. And if you look at the pre-lubricated ones, they're actually superior to the regular PVC ones. So again, different ways of measuring, slight differences. So to summarize, I think in terms of urethral trauma, certainly the hydrophilic catheters should cause less trauma. They're going to slide in more easily. They're going to have decreased rates of hematuria, decreased bleeding episodes. There's not one hydrophilic catheter better than another, but again, very limited evidence out there. Strictures is another one. So every time you pass a catheter and you cause trauma, you have the risk of developing a stricture. 4 of these 5 studies showed that the stricture rate between the two was really no difference. And over again, I don't think stricture has really been shown to be dependent on the type of catheter used. So that's not a great surrogate. It doesn't really tell us a lot. So again, in terms of recommendation, I would tend to lean towards the use of a hydrophilic coated catheter. Again, if it's available, we think it causes less hematuria, but there's really not a lot of evidence to say it causes less macro trauma or even stricture formation. So how do patients do? How's their actual quality of life? Are they happier? So, intermittent catheterization has certainly been shown to improve overall quality of life. And it lessens the restrictions on daily activities. They're more mobile. They're more able to be independent, our patients. They can improve even sleep, social function, sexual function, overall quality of life. It's a real game changer, the introduction of intermittent catheterization by Lapides. And so you really have to have acceptance by the patient, and then ultimately you're going to have a satisfied, happy patient in the long run. However, unfortunately, a lot of patients end up getting a negative quality of life because of some of the complications like infections, like the social stigma of having to carry on catheters or having to clean them, etc. And so it is a little bit of a double-edged sword. Generally, people are happier, but I wonder whether there's ways that we can make them have a reduction in some of the negative aspects of catheterization. So when we're looking at patient satisfaction, there's a couple things. Whether they're satisfied with the treatment, whether they're satisfied with the education they receive, that's a big one. It's hard to get say a nurse continence advisor for every patient. They need a good support. They have to have good access to materials like catheters and lubrication and the variety of catheters. And we really want to make it easy for them. We want it to be minimally interfering with their daily activities and, of course, avoid all those complications that we were describing previously. So there's been a number of studies looking at outcomes. It's actually only these sort of patient-reported outcomes has only been in one study, and there's a number of factors that are at play here. So this study by Kessler showed a fairly high patient satisfaction in terms of quality of life in a group of both neurogenic and non-neurogenic patients who were followed they'd been on catheterization for 5 years. They're catheterizing about 3 times a day. And if you look at the results, pretty much in the 80s, right? 80% of patients found it easy or very easy. 82% reported little to no interference in daily activities, minimal pain, and it improved their quality of life by 60%. So intermittent catheterization, it's a worthwhile strategy. It's well accepted. We just need to find the right patients for sure. I mean, this group was a bit of a hybrid group, neurogenic, non-neurogenic, so it could skew the data, but certainly I think it's going in the right direction that if you ask patients, you treat them well, and you teach them well, they'll probably be quite happy. There's been a number of studies too, especially in children, looking at whether the catheter material makes a difference in terms of quality of life and preference. There's certainly higher satisfaction for the hydrophilic coated catheters and as well as the pre-lubricated catheters. So these sort of higher end catheters tend to work better, and I don't think that's a surprise. They're probably better designed. There is no, however, data really looking at quality of life in patients who reuse catheters versus the single-use ones, and I think that gets into a very interesting area because on the one hand, we tend to historically recommend reuse in Canada, but we haven't really looked at the impact in terms of quality of life, not only in the experience of catheterizing, but also perhaps in the experience of carrying around catheters, thinking about where you're going to sterilize them, certainly if you're out in public or going on vacation. So I think those are factors to look at, certainly in future research. So intermittent catheterization is absolutely the preferred method of bladder drainage for patients who have both neurogenic and non-neurogenic voiding dysfunction. We've seen, and we've all seen in our practices, and the literature would certainly support the fact that intermittent catheterization leads to a significant improvement in quality of life of our patients. It certainly will reduce the risk associated with retention and incontinence. Patients are happier as a result of being dry. It reduces or actually takes away those risks associated with indwelling catheters, which is a major step forward for patients. And if you know much about global health, there's actually parts of the world where obviously intermittent catheters would not be available due to cost or resources. And there are people who live with indwelling catheters for years and don't get them changed. They're just in there. So it's quite remarkable how it can improve quality of life. Intermittent catheters have definitely been shown to enhance both the independence, social, psychological well-being of our patients. I think the idea of acceptance and long-term compliance is an important one. I think it gets down to that very early, careful education and support that patients really, really need. And there seems to be a preference both in the literature with respect to outcomes as well as patient preference with respect to single-use hydrophilic catheters. When we look at quality of life, cost effectiveness, there have been a number of studies looking at cost, and I think that's an important factor because if we're having these better, perhaps more expensive catheters, are they worthwhile? Do they actually result in a cost effectiveness analysis? There's actually been 8 studies. They're all doing a cost utility analysis. 6 of the 8 actually concluded that intermittent catheters with hydrophilic coating were cost effective in their various areas, UK, Japan, Canada, Brazil. There was one that actually didn't find support for cost effectiveness, but it was kind of used based on reuse versus single use, reuse of single catheters. And then there was actually an Ontario study that found that neither single-use hydrophilic or multiple-use uncoated were cost effective. So that's an interesting take on it. So there really hasn't been a formal economic analysis when you compare clean versus aseptic. There was 3 trials that have been done. None found a significant difference in UTIs. But in a non-randomized study, the aseptic technique was associated with a much higher cost compared to the clean technique. So you have to ask, is it worthwhile? That is the question about cost effectiveness. So the NICE guidelines, which is the United Kingdom's way of looking at health economics, actually suggested that intermittent catheter reuse may be cost effectiveness compared to single use. However, and there's always a however, reuse of single use catheters was not deemed a suitable comparator. So there was a question about whether doctors and nurses would actually be liable for infections if people were reusing single-use catheters. Again, it's off-label. So an example would be if I tell a patient to reuse a single-use catheter and they get some terrible complication and they sue me for giving them a recommendation off-label against Health Canada's recommendation, am I liable for their infection? So that's an interesting sort of legal spin on it. And then again, you're sort of telling people to ignore the single-use symbol, and are there implications for that? Ontario did an analysis as well, systematic review and economic analysis. They definitely showed that there was a significant decrease in cost in QALYs, so quality adjusted life years, when reusable catheters were compared to single use. So they actually concluded that the most cost-effective approach would be to use 1 catheter reused per week. So that was sort of the happy medium that Healthcare Ontario HQ came up with. They actually said, well, we may not be able to fund unlimited numbers of hydrophilic coated single-use catheters, but we also don't necessarily recommend that Ontario folks use a single catheter forever and ever and ever. So the most cost-effective approach was a reuse of one per week. That's based, again, on their numbers. Now, you could change the metrics, and you may get another outcome. And in fact, there were some limitations with this analysis. They really hadn't looked at, there's not a lot of prior research looking at the reuse, so they made a lot of assumptions. When I looked at, and when we've looked at the cost that they use for these hydrophilic catheters, it was a very high cost. So it's sort of like saying, I'm going to do an analysis on how much it is to drive a car every month, but I'm going to do it based upon the price of a Rolls Royce. So that didn't really make a lot of sense because they didn't look at like the average price of a catheter. And again, it didn't sort of look at patient factors like acceptability, satisfaction, etc., or the cost associated with infections or catheterization. So some limitations you might want to consider. This is a study that I was involved in. Blaine Welk is in London. I was a senior author, and we looked at cost effectiveness comparing hydrophilic coated versus uncoated catheters. We actually found that hydrophilic coated catheters were most likely to be cost effective compared to uncoated catheters. And again, that was in a Canadian public payer perspective. So, from a societal perspective, we actually found that hydrophilic coated catheters were likely to produce cost savings. And we looked at a number of indirect patient factors like pain or time and the steps to place a catheter. So we took a slightly different look at the cost associated with catheters and came up with a different conclusion in favor of hydrophilic coated catheters. So for now, I think this is a bit of a soft recommendation. I mean, we certainly think that patients should be offered the use of a hydrophilic coated catheter. So far, the health economic evidence really still supports hydrophilic catheters to be cost effective. But again, the amount of data, the amount of randomized trials is really limited. So final conclusions, I think we're right on target for time. Intermittent catheterization does remain absolutely the gold standard. The type of catheter material, the cleaning method, the catheterization technique, however, does remain a bit of a controversial topic, certainly in urologic circles. The preferred intermittent catheterization strategy really depends on settings and practices, and there's absolutely no evidence that there's one best catheter for all patients. So I'm not here to advocate for one particular kind. Patients who are in a wheelchair with limited dexterity are going to be very different than patients who are, high function, mobile, with a different medical condition. So I do think there's a need for selection of the ideal type of catheter, the ideal technique, which is going to be a balance between the patient's motor function, their acceptance of the procedure, the quality of life that they are trying to achieve, as well as the available resources in their community. We think that single-use catheters remain the optimal strategy until evidence supports multiple use. Certainly, reuse of catheters is still in clinical practice, again, despite some concerns about the ability to clean it properly and compliance with these types of cleansing techniques. So I think whenever possible, it's almost like a stepwise approach. If we can, whether it's an issue of coverage or funding, a hydrophilic coated catheter or a pre-lubricated catheter is probably the best first treatment. The evidence, even though it's limited, does support lower rates of infection, lower rates of trauma. There's this added convenience over these uncoated reusable ones. And certainly so far, cost effectiveness, I think, is leaning towards the single-use hydrophilic catheters in a public payer perspective when you are looking at all the patient factors. And I'll remind you that in other jurisdictions around the world, it's covered. It's not even a debate. So I find that very interesting. So at least here in Canada, the debate continues regarding what's the best catheter material, the technique. So there's an opening for high quality trials and certainly a voice amongst the nurses, specialists, and people who care for these patients, because many of them don't really get a voice, and we need to advocate for them. So with that, I will thank you very much. I will hand my screen and the talk back to the moderator. Thank you.
Hi, thank you very much, Dr. Elterman. A very interesting and shock-provoking presentation. And if you can just stay on the line for just a few more moments, what we would like to do now is invite Deb Cutting to introduce a project that has been in the works for the last year or so. I just wanted to know, Deb, are you on the line?
I am. Can you hear me?
I can hear you. And can you see the
Yes.
slide on my screen? So Deb,
Great.
Deb will just do a brief introduction, and then we're going to come back and field questions. Both you can ask the question or you can type it into the chat line, and we will start fielding questions as soon as Deb is done. So this is Deborah Cutting, who's an NSWAC, WOCCC, and an NCA.
Hello all. I just thank you, Kathy, for this opportunity. I just wanted to give you the heads up about this NSWAC. Began as an NSWAC initiative, but it has turned out a group of 11 of us for the last just over a year have been working towards coming up with publishing a Canadian nursing best practice recommendations for intermittent urethral catheterization. So I have really enjoyed the collaboration between NSWAC, the Nurse Continence Association, Infection Prevention and Control in Canada, and the Urology Nurses of Canada. So that's been exciting that we've been able to bring these three groups together. As you have just heard, unfortunately, there is really no strong evidence on most aspects as it pertains to intermittent catheterization. So we have to walk a fine line between expert opinion and all of the various studies that we've come up with in our lit search, which of course was so eloquently outlined by Dr. Elterman just in this presentation. So we're hoping that the end of 2019 we'll see these recommendations ready for publication, and we hope that they are useful in your practice.
Yeah,
I think that's all for now, Kathy.
Okay, thank you very much, Debbie. It's a really exciting project, and it will be presented at the May 21 to 24 NSWOCC conference in Charlottetown, PEI, and we're really looking forward to that. I wanted to, in addition to the 4 organizations working on this project, is to acknowledge that this evening's presentation by Dr. Elterman was supported by Coloplast, and we thank them for their support, and also the Canadian Nursing Best Practice Recommendations for Intermittent Urethral Catheterization are supported by Hollister, Convatec, Coloplast, and Bard. And now we would like to move into the question and answers, and I'm going to get it started. And there is a comment here from Jillian Brooke. It's more comment than question. The comment is, the challenge in Ontario at least is the funding. The LINS will only provide enough catheters that it requires reuse. This puts service providers in a difficult spot and relies on great documentation about the attempt to try to obtain sterile, and education is provided. The liability issue is always concerning given our hands are tied. We do determine if a client can pay or if there is insurance or other types of funding, but it's still a challenge. So thank you very much for that comment. I would like to open it up. Does anybody online have a question that they'd like to ask? If you do, if you could unmute your mic in the bottom left-hand corner and just identify who you are and ask your question. Does anyone have any questions or comments?
I'm actually going to comment. It's Dr. Elterman. I'm going to comment to that first comment while everybody sort of prepares their questions. I think that's an excellent point. And, you know, I think it's in the hands of organizations like NSWAC and the UNC and the CUA to really be a voice for these patients. You know, I think it's unfathomable, in fact, that Canada is one of two OEC countries, the other one being, I think, Zimbabwe, that doesn't cover intermittent catheters to the appropriate levels that are required. And I think there's an argument here for, you know, it's almost like a human right. I mean, certainly patient dignity is not taken into consideration. I think that if we were asking Ontario patients who had colostomies or ileostomies to clean out their bags and reuse their supplies, there would be an uproar and it would be unconscionable. So the fact that I, as a urologist, have to place patients on intermittent catheterization and tell them that they have to take this piece of latex, PVC, that's been designed to be used only once, and that they have to carry it with them in a plastic bag and bring soap and sanitizer everywhere they go, I think it's a little demeaning, and I think it's a bit sad that in Canada, this is the state of affairs, certainly in Ontario. So I think there's a huge role for us as healthcare providers together to really be a voice for these patients.
Yeah. Thank you, Dr. Elterman. We have a question here from Laura Robbs. Is there any difference in the literature as far as the use of coated catheters in men versus women?
Yeah, so, you know, a lot of the studies, well, there's a mixed bag, but certainly, you know, the risk of urethral trauma, the need for sort of fancy hydrophilic coating and pre-lubricated catheters, I think, is more important in the male patient, only because the male urethra is just so much longer to traverse, with more sort of bends along the way and more areas that you may come into problem with. So it's not an issue of men versus women, but I do think that the literature would tend to support the use of hydrophilic catheters more strongly in men, just because I think they're probably going to be more prone to having challenges.
Okay, thank you very much. We have another comment here and question. Hi, my name is Jeanette. I work as a community nurse. It may have been already covered, but I think I missed. What is the recommended length of reuse for a catheter?
So the on-label recommended length for reuse of a catheter is 0, because they're technically all designed for single use. That being said, I know that the CUA, the Canadian Urology Association, does have a patient brochure that, if I remember correctly, I think it's either a week or two, or when your catheter becomes, like, the material begins to sort of degrade. The Ontario review, and that was more from a cost analysis, said 1 week. So if you had to put a number on it, maybe 7 days, but I don't think that there is research looking at the amount of time. If you have a specially designed catheter, any of the catheters, particularly the hydrophilic coated ones, every time you re-sterilize it or clean it, you're stripping away the lining. And so you may not be able to see it to the naked eye, but you're actually degrading the material. And as a result of that, you're going to lose its lubriciousness, and it's more prone to causing trauma because it's just lost its surface integrity.
Yeah, thank you. We have another question here. Actually, this one kind of springs into the last comments that you made, and that is, what is the recommended cleansing for intermittent catheters, if at all?
So there have been a few studies looking at boiling catheters, soap and water, alcohol sterilization. The current leading recommendation is simply warm to hot water with soap, like dish soap, and allowed to air dry on a paper towel on a cabinet so that it dries. The problem is that if you're on the go, like a patient, and you clean it in a public washroom and you throw it into a Ziploc bag, it doesn't really get a chance to air dry. So, presumably something that's wet is more likely to form things like mold. So that's a consideration. But generally speaking, soap and water under warm sink and allowed to air dry is the quote unquote recommendation for cleaning.
Okay, thank you. The next question is, has anyone approached Health Canada to have their feedback about the reuse of a Class 2 single-use device from a regulatory point of view?
I don't know. I think it would certainly be interesting. I think it almost has to come from a patient who, if Ontario or some province is saying, listen, we're not going to fund you for more than one catheter per week, and you either call your Minister of Health or you call Health Canada and you say, I'm being forced to use a Class 2 product that's deemed to be single use only, it's the type of thing you could take to the courts. But to my knowledge, no.
Okay, thank you. The next question is, thank you for this great presentation tonight. Can these same recommendations for intermittent urethral catheterizations be applied to patients with Indiana pouches? This is another group of individuals who struggle with infections, trauma, and stricture development over time.
Yeah, I don't know if we can make certainly extrapolations to other types of urinary diversion or continent catheterizable stomas or that type of thing. But I do think that those patients face many of the same challenges where they're going to be chronically colonized. They're having to traverse, whether it's a conduit, it's a little bit more curvy. If they have to pass, say, a nipple valve inside. So again, they're not a group of patients who should be discarded. They're unique to your sort of neurogenic, non-neurogenic group, but they do also, I agree with you, have very similar struggles.
Okay. What is your take with regards to using is it COUDE tip, COUDE tip catheter for men, or should we be using this type for those with large prostate only?
Yeah, so it's a coude. There's an accent aigu on the end of the E there, so it's a coude, like a French name. It's designed to have a bit of a curve, like a hockey stick at the end. And the idea is that it will gently follow the male urinary passage up over the prostate and the bladder neck to allow for greater ease of passage into the prostate, into the bladder. The coude tip catheters tend to be, I think, a little bit more expensive. That being said, 50% of 50-year-old men will have an enlarged prostate, and 80% of 80-year-old men will have an enlarged prostate. So you've got a fairly high chance that you will have a challenge passing a prostate in a male patient. And so certainly older men over the age of 50, it might be recommended. It may not be as necessary in young sort of neurogenic spinal cord men. Yeah, so that's my take on it.
Okay, thank you. Hang on one sec. The screen just moved forward. Okay. What would you recommend for frequency of change for a Foley catheter for a patient who cannot perform CIC but is prone to frequent urinary tract infections? Monthly, biweekly, or weekly? And also, what do you recommend about flushing, indication and frequency?
Yeah. So the general recommendation is someone who's living with an indwelling catheter, we want to change it every 4 weeks. For whatever reason, if it had to stay into 6 weeks, that would be a push. In those patients in whom are getting recurrent infections, I change them to changing it every 2 to 3 weeks. Obviously, if they have the resources, it could be changed weekly. So it's one of those things where you could reduce it by a week from 4 weeks to 3 weeks, see how it goes. If you still feel like they're getting a lot of infections, symptomatic, remember, not just bacteriuria, you could do it to every 2 weeks. In terms of flushing, if you're changing a catheter pretty regularly, you're not going to have to flush it all that often. Now, if for some reason the patient has a lot of debris in their bladder, the idea is not just to flush the catheter, but to actually irrigate out the bladder. Flushing a catheter is just going to keep that particular catheter in. So if you leave it in for 3 weeks, 4 weeks, 5 weeks, and they tend to collect a lot of debris, then you can flush it to remain patent. But the key actually is not just to flush, but to irrigate. So what I would do is I take a 60 cc catheter tip syringe, and I fill their bladder 2 or 3 times, so 120, 180 mils. Then I sort of
Dr. Elterman, we've lost your sound.